Thank you everybody for coming. I got interested in the shoulder because probably for the same reason Dr. Park got interested in the foot and ankle is you get to focus in on one area. In orthopedics you can do different specialties. You can do joint replacement, which is hips, knees, and shoulders, or you can do sports medicine, which is arthroscopy of hips, knees, and shoulders, or you can really focus in on one area. And I thought that focusing in on just shoulders and elbows is another part of my practice, but just one area really let me do all kinds of different procedures and get to know one body part very well. So I get the chance to do arthroscopic procedures. This is the rotator cuff tear, and this is the arthroscopic picture of a repair. I get to do cases like this. You can tell this does not look like a normal ball and socket. This is a 35-year-old whose joint is completely arthritic. And I get to do things like this. This is somebody that came in after a fall, and you can see that this is in multiple fragments, and we get to put that back together with plate and screws and restore the anatomy. So lots of fun to do all kinds of different things like that. As far as my private practice goes, we have 7 physicians in our group, and you'll hear from another one of them in a second here. And I think that I do shoulder and elbow, but we really are a one-stop shop for everything. So we do take care of all the body parts, all the procedures, pretty much anything you can think of. We can, at least if not the one that you see, can take care of it. We can get you the right person. I also have a unique opportunity. I get to work down at Harvard, UCLA, and I'm there 2 days a week. This is a county facility. It's a teaching hospital. We have residents that I get to work with and teach. It's very trauma heavy, so this is where most of my complex scapular, elbow, different types of shoulder trauma comes into play. This is sort of a typical example of what I might see at Harvard. This is a 36-year-old man who was shot by his own cousin because he owed him $50, and you can see that the ball is just blown to pieces. And if you look at the CAT scan, you can see that this is the socket. The joint surface is in multiple pieces. So at 36, we didn't really have a choice other than to replace his shoulder, which is really drastic and radical. It's very rare that I would have to do that to somebody so young, but it didn't really leave us much of an option. So speaking of the shoulder, it's certainly complex. I think that all the joints are complex. I think the shoulder is more complex than a lot of the others, but Dr. Park might think the ankle is more complex than the others, and so on and so forth. It's capable of a lot of tasks, and unique to the shoulder is that it does have the largest range of motion of any of the joints. And while it's sort of a double-edged sword because it has such advantages, but it also leads to some significant problems as well. This is just a funny picture. This is from one of our old articles, and one of our famous mentors, Dr. Rockwood, actually took medical students, and to check the range of motion of the different bones, he would actually insert these little darts in their bones. So this is sticking in this guy's clavicle, and he's a quote-unquote willing participant in the study to find out exactly the range of motion of shoulder. So he would actually take a compass and try to figure out exactly what it was. The shoulder is frequently injured. It's injured from all kinds of activities. Sports is certainly common, but I think more common for us actually in this area is work injuries, whether it be one-time direct blow type injuries or more commonly probably repetitive use, so stacking heavy things up on shelves and repetitive overhead use. Then there's certainly maturity, which, once you need your nurse to hold you up while you're swinging your golf club, then I wouldn't say you should give it up, but you might be expecting to have some more injuries at that point. These injuries are starting earlier and earlier as sports have gotten more competitive, and they do have a significant cost to society. Let's see if I can take that. I'm hoping these will play. This is one mechanism of injury right here. Not sports, not work related, but it's painful nonetheless. As far as the shoulder goes, it's often a team approach. I have a lot of communication with our physical therapists. We have physical therapists on staff, but I also have a good relationship with physical therapists all over the community, so I'm in constant communication with them. Unfortunately, there's less physical therapy allowable every year, so between Medicare, private insurance, workers' comp, whatever it may be, you'll notice that you don't get 40 visits a year anymore. You get 18 or 20 visits, so we really have to make do with what we have and really make the most out of it. As far as my office encounter, the history and physical exams still remain crucial, so despite MRIs and fancy tests and whatnot, This really is what it all comes down to. This is what most of our 4 years of med school is spent on, is listening to you, listening to your complaints, examining you carefully, and that gets us 90% of the way there most of the time. As far as images, they are of course important, and that's sort of the next step after the physical exam. I always start with an x-ray, and people often wonder why, and I'll talk about that in a second. But certainly an x-ray can look very normal, like you see here, ball, socket looks nice and normal. But when you look at the MRI, you can see that this is the rotator cuff that is not attached anymore here. So the MRI is very helpful in that case. I would put beware of the labral tear. I think many of you have probably experienced this if you've ever had an MRI scan. It is very difficult to get an MRI scan on any shoulder and not have the read say that you have a labral tear. I think it's very difficult to diagnose a labral tear. I'm not even sure if labral tears truly exist in a lot of the populations of patients that are getting them. So I would not put a lot of stock in it if you see labral tear on your report. That's something to talk to your physician about, because this is a dangerous thing. If you see labral tear, you can easily get talked into getting it fixed or having surgery on it. Oftentimes this does not need it at all. It can be physical therapy and things like that. There's a myth that an MRI is better than an x-ray, so oftentimes I find myself talking to patients and they're saying, I don't want an x-ray, just send me straight to the MRI scanner. There are certain diagnoses that you just can't see on an MRI scan. And calcific tendonitis is one of them. Arthritis is another good one. But you can see here, by all intents and purposes, this is a normal-looking MRI scan. And this is the rotator cuff coming along here. And you would flat out miss that this patient had a huge piece of calcium in their tendon. So this is the same color as the tendon on the MRI scan, and you just can't see it. And so this is an easy diagnosis to make. It saves the $1,000 MRI scan that's unnecessary, and you don't even miss it because you get it and you can see it. This is one of my favorite things to treat if it ever gets to this point, just because it's kind of fun surgery to do. But you go in there arthroscopically, you can see, you have to localize and find where that calcium deposit is, and that calcium acts almost like a hot little marble up in there, and it causes this inflammation that is so incredibly painful that it's one of the things that can get you to the emergency department without an actual trauma. And you can see all of the pieces coming out like a snowstorm. And it's incredibly relieving once you get to this point. Again, this is something that we always exhaust all of our non-operative treatment before we get to this. So this person has had 3 cortisone injections, they've had physical therapy, and they are that small group of, say, 5 or 10% that didn't get better with those things and had to get this done. So you can see it's right in the middle of that tendon.
So how do you absorb those particles?
When they are inside of the tendon, they're almost, they can't be accessed by the body. So the idea here is to release it. It's almost like an abscess, a tooth abscess. It has to be opened and drained because it walls itself off and the body can't get to it. So this really is the idea. Once it's out in the space and out in the open, the body can break up all the little particles. It's when it's contained in that sac that you can't get to it. There's more of it. It's like toothpaste. So we talked about the anatomy just a little bit. The shoulder is complex. It's really not one joint, it's 4 joints. And so if you look here, you can see there's a ball and socket. That's the real shoulder joint, I guess, or the glenohumeral joint, the glenoid and the humerus, the glenohumeral joint. There's also the AC joint. This is the acromion and the clavicle, so the acromioclavicular joint. This is where you get a shoulder separation. So if you see one of the bicyclists or a football player land right on their shoulder, this is often what you get as a shoulder separation. Down here is where you see a shoulder dislocation. There's also a joint where the clavicle meets the sternum. So this is the sternoclavicular joint. That's in fact where most of the rotation happens through your shoulder. And then lastly is the shoulder blade as it sort of articulates with the chest wall, so the scapulothoracic interface. When you open up the joint, you can see that all the joints really are the cartilage surfaces surrounded by a bag that holds the joint fluid in it. So this is the capsule, and the capsule is what holds that joint fluid in. This is also what makes up the ligaments that hold the joint together. Outside of the capsule, so going outward complex. There is a large spectrum of treatment. I think it's interesting that there's still huge disagreement amongst experts. And so when we go to these conferences for a weekend, we sit and listen to debates about what I'm talking about. Labral tears, are they real? Are they need to be surgically treated? Does it need physical therapy? So on and so forth. But no question still, the proper diagnosis, rehab, surgical treatment is crucial. Revision surgery is rarely as good as the primary surgery. So you really want that first surgery to be indicated to be properly performed and rehab appropriately afterwards, because that's kind of your best shot at it. Whenever we go back in for revision surgery, it's always a concern that it's not going to be as good as it would be if we got it done properly the first time. So looking at the rotator cuff, this is a common area that we talk about. The rotator cuff is made up of 4 different muscles. There's the subscapularis in the front. There are 2 muscles on top and 1 muscle on the back. And if you look from the side, you can see that the 4 muscles together create this cup, if you will. So this is a cup of tendon. When you get a tear, and those muscles are there to rotate the ball and to help pull the ball into the socket so that you can reach your arm up overhead. They're small, they're not strong individually, but they have a very important purpose. Rotator cuffs issues, not necessarily tears, but partial tears and bursitis and tendonitis. This is the most common reason that I see patients. All day long, any patient over the age of 50, I'm almost certain that most of them are going to be this. This is typically seen in patients who are age 45 to 65, and these are wear and tear tears. People often wonder, well, I didn't do anything. How did my rotator cuff tear? And it's just a wear and tear phenomenon. It's not necessarily that you swung that big mallet for years and years. I think a lot of it has to do with genetics, a lot of it has to do perhaps with diet. We're not really sure, but inactive, sedentary people can get rotator cuff tears just as much as people who are active, so it's very hard to say what causes it. Also, many patients have full thickness tears and don't even know it. There's an interesting study out that took an MRI of 100 patients with no shoulder pain whatsoever, and over the age of 60, and a third of them had full thickness rotator cuff tears, didn't even know that they had them. So that can be a red herring when we do get these MRI scans, so we have to be careful not to jump in and do surgery on all of these, because they may be sitting there and may be asymptomatic. These are one area where I'm fairly aggressive, because these are issues that can get worse if you leave them alone, and it can lead to problems in the future. Now, this is a dramatic incident, so don't think that if you come to my office tomorrow, your shoulder is going to look like this. But this is a woman who has no rotator cuff left after multiple surgeries, and she has this very little control of her shoulder. And you can see that she just, as she reaches, side too. But again, as I said, that rotator cuff is designed to hold the ball in the socket, so she can't initiate her arm to raise it overhead. Now I can hold it in place and raise it up, and she can hold it up there because of her other muscles, but she can't get it up there herself, so it's pretty dramatic. But with time, these tears can get bigger and get worse and get harder to fix. Rotator cuff disease comes in a whole spectrum of disorders. When I say full thickness tear, that separates sort of the bad ones from the good ones. And full thickness means that the tendon is actually torn off of the bone. Prior to that, you'll hear lots of terms, and this is what most of what I see is patients who have things like impingement, bursitis, tendonitis, bone spurs, partial thickness rotator cuff tear. In my opinion, these are all the same process. This is gray hair and wrinkles in your rotator cuff, and it's a slow aging process. And these are all the same thing. Because patients will say, well, what about the bone spur, tendonitis, and so on? They're all the same. And really what these are early rotator cuff tears. And it's sort of the spectrum of disease leading up towards full tears down the road. The problem is these all look like full thickness tears on physical exam history. So that's where an MRI really comes into play for rotator cuff problems, after your good history of physical exam. For early stages of rotator cuff disease, I'm going to do typically physical therapy and cortisone injections. Full thickness tears will not heal, but we can make them asymptomatic. We can do physical therapy and cortisone shots and make them not hurt anymore. So depending on your age and activity level, we may choose not to fix that tear, knowing that it could slowly become a problem for you. And that's stuff that I discuss in the office with patients. This is a full thickness tear. And the surgical treatment of this really depends on a lot of factors, like I talked about. So you can see, when you have a tear in the rotator cuff, usually most of the tendon is still intact, so all the way around is intact. It's typically just a small portion that's torn. And so you still have the capacity to do all the things you need to do with that shoulder because most of it is still intact. It's this part, it doesn't cause a weakness or a loss of motion, it causes pain. That area is very painful, and this is the small tear that we can oftentimes address by strengthening the rest of the rotator cuff, sometimes giving a cortisone injection around this area to quiet down the inflammation. Here's a clinical picture of what it looks like. You can see this is that hole, but again, tendon intact all the way around. The patients that I typically am more aggressive with, younger patients, patients that have been torn off traumatically, somebody has a motorcycle accident and tears it off, those are fresher, I think those are more likely to do well with surgery. And then the larger the tear gets, the more likely I'm to intervene before it gets to be a problem. Surgical treatment is easy, it's a piece of cake, it takes an hour, it's outpatient, it's the recovery that is brutal, and that's the part that scares everybody. 6 months is the minimum. 6 months is where you get back to doing most things that you need to do. 18 months is probably how long it really takes for that tendon to fully heal back down as well. It's by far the hardest tendon to get to heal in the body, and we have all kinds of measures that we try, but it's a very slow rehab process for that reason. This is just a video of arthroscopic rotator cuff repair and what I do surgically. So, see here, this is that tear again. That's the joint surface over here. This is the footprint, if you will, of where the tendon needs to be. I'm cleaning it off and removing tissue so I can freshen this area up to put my anchors in. This is the tendon right here. You can see that's that same hole that we looked at before. And now I'm just localizing where those anchors are going to go. Here's the anchor. You can see it's just a metal screw or plastic screw that has stitches attached to it. There's no difference in healing time between an open repair and an arthroscopic repair. We do the same thing, it's just a matter of having fewer incisions and possibly less pain afterwards, but the rehab is no faster when we do an arthroscopic. It's one of those other myths that's out there. You can see it's just really simple sewing from here. It's needlepoint. It's basically taking this and sewing it up through the tendon. And I had access cannulas. See, it just basically shoots it right up through, passes the stitch. And then at the end I have a knot tire that I can cinch down and tie down. Plastic anchors, there are metal anchors, there are anchors like this, but which actually turn into bone with time. They're biocomposite anchors that turn into bone with time. And if you look, you can just see that basically now this is the tear. It's pushed, it's tied down to the bone, and it has these stitches over top that are draped down. You're pressing it down. The other part that you can see from the video is this flat part of the shoulder blade. The bone spur that you hear about and talk about, really all it is the patient's own shoulder blade. And so this is part of the procedure is to shave down that area to try to make more space for the rotator cuff at the end. So a bone spur really is just your own shoulder blade. Moving on, that's rotator cuff tears, frozen shoulder. I have 4 different topics I'm going to talk about, so I'll go through these a little bit faster so we don't get too caught up. But frozen shoulder is an interesting one. I see tons of frozen shoulders. It's actually pretty common. 2% of the population is more frequent in women age 40 to 60. There's a higher correlation with diabetes, but most of the patients that come into me with frozen shoulder don't have diabetes. This is picked up with history and physical exam. MRI really rules out other things, but I typically don't even give an MRI scan on these until they're well into it if they're not making progress. Frozen shoulder is an interesting phenomenon. It's very frequently misdiagnosed by primary doctors, by orthopedic surgeons, by everybody. It presents as pain, and I think that's part of the reason. So patients come in and they don't want to move their shoulder. Realistically, in reality, it really is a stiffness problem causing the pain, not a pain problem causing the stiffness. And it's not really talked about. I think when you talk to your neighbors, everybody on the street has had rotator cuff something or other done, and their rotator cuff surgery, and their arthritis, and their hip replacement. But as common as frozen shoulder is, I never hear about it. And I feel like I do a lot of educating about frozen shoulder. Most people really, if they've heard about it, it's a lot of misconception, or they've just never heard about it before. These patients are miserable for a long period of time. It's incredibly easy to diagnose, but it's scary because we don't know a whole lot about what causes it, and it looks a lot like impingement or bursitis when it first starts. And so a lot of times patients will get surgery in that initial period when they probably shouldn't be getting surgery because of the inflammation that they have. So here's a case. So you look at this patient, she comes in and she says, my shoulder has been aching for 2.5 months. There's usually some remote history of trauma. She says, I picked up my child's backpack on the way to school, and I think that must have done it. And you think, well, that sounds funny why that would cause pain like this. There's usually some remote trauma, but you can see, you say, well, it can't be a frozen shoulder because she's got great range of motion. But if you compare to the other side, you can see that she really does have a loss of range of motion. So this is the frozen side, and this is the non-frozen side. You can see there is a subtle difference. Look at this one goes to here only, and this one goes back to here. And then when you look at her behind her back, it's clear that this is what she has, the frozen shoulder. This could easily be misdiagnosed as something else. Here's just another video showing sort of the subtlety of it.
All those who need mental.
See that here's another patient. Women, age 40 to 60 usually, but even then it's only a 3-to-1 ratio, so I do see men with this. Sorry, I tried to block her face. You can see that the right side just doesn't have the same mobility as the left side. So I spend a lot of my office visits trying to convince patients that this is what they have. They've never heard of it before. They can't imagine that this is what they have. Now this happens at the capsule layer. So again, there's a joint, then there's a capsule, then there's the rotator cuff outside of that. This is at the capsule layer. And what happens is you get this, the capsule is like satin. And because of this microscopic molecular process, the capsule turns to shoe leather. And it gets tight, and you can see this normal capsule turns to a tight, obliterated, scarred, thick capsule. Patients start with a freezing process where they hurt a lot. Then once it's frozen, the pain starts to get better, and then the thawing process takes a long time. This can be at least a year. Some say upwards of 3 years before they finally improve. Typically, the patients are treated with gentle stretching exercises. It doesn't need a lot of physical therapy, but most of this is education. Saying, I tell patients, go look in the Mayo Clinic website, go look at Cleveland Clinic, wherever you want to go look at, whatever you think is the great place, go look at it and see. They will have a whole section on frozen shoulder. I promise you it exists, and I promise you it's what you have. And it is hard to convince people, but typically they'll come around. Only 10% of these patients actually need a surgical release. In the old days, we used to just take the arm and put them to sleep and just crank on it. Now it's at least a little bit more elegant than that. So now it is typically an arthroscopic release, and you can see this capsule should be thin like satin pillowcase, and it is thick stuff. It's like shoe leather. So here I am just coming through, and you can see that beyond this layer is going to be muscle of the rotator cuff. Because again, we're inside the joint, we're working our way out. This is the capsule. The rotator cuff is outside. The rotator cuff is fine and normal. It's just a tight, stiff, painful shoulder. Again, only 10% of people will ever get to the point where they need this done. So you can see this is an actual fighting instrument. It actually is just like a little clamp, and I just go up and chop away. Rarely comes back. Yeah, especially after this. Very, very, very rarely comes back. It's way more common to have it on the other side than to ever get it again on the same side. See, that's all rotator cuff muscle back, sort of behind this capsule, if you will. Let's see a good shot of that in a second. That's all the rotator cuff muscle behind. You see that? Okay. Moving on, 2 more topics. Shoulder instability. The shoulder, again, like I talked about, has the most range of motion of any joint in the body. So that's great. We can throw javelins, and we can swing from branches, and we can do whatever we want to do. But it also yields some instability. So that shoulder is the most commonly dislocated joint. Again, about 2% of the population. This is more of a younger person's issue. 50% occur in patients in the ages 15 to 29, but not necessarily. I see patients in their 40s, 50s, 70s, 80s who dislocate their shoulders. Typically, males make up about 80% of dislocations. Again, this is a common sports injury, but it's also a common work-related injury. It's recreational athletes and all kinds of different people. And typically, it's a traumatic event. We try usually to get a close reduction. That means put a patient to sleep or numb them up some way and just put it back in the joint. Hopefully, that takes care of it, but not always. Young active males typically have a very high recurrence rate, meaning that they would go out a few months later to play that sport again or do that activity, and out it comes again. And now it becomes a recurrent problem. The reason it's so unstable is because the shoulder does not have a lot of inherent stability to it. It's really just a big ball sitting on a small golf tee, if you will. So there's not a lot holding it in. It's not like a hip joint where there's a lot of bone to hold it in. So you really are relying on these soft tissues, and this is what the labrum is. The labrum is, let me show you this picture. The labrum is this socket, this tissue around the socket. It acts almost like a suction cup, and it expands the socket and holds that bone in place. When you get a labral tear, when the shoulder pops out of socket, it doesn't rip this like a piece of paper. It rips it off of the bone like this. So it takes that labral tissue and disrupts that suction cup effect of holding the ball in place. And so to do surgery, we're typically going in and repairing this along the rim of the socket. This is a case where you might hear about an MRI arthrogram. This is an MRI dye injector. This is all dye in here. The reason we put the dye in certain occasions is to see, you can see the dye leaking in here. Shows that this is the labrum that's separated off of the bone. Again, like anything, like all of these, initially we're going to try non-operative treatment. We're going to try physical therapy. We're going to strengthen the rotator cuff and all the muscles that hold the ball in the socket and see if we can keep it from dislocating again. But if not, we have to get to operative treatment. Typically, operative treatment is going to be younger patients. It's going to be patients involving contact athletes and patients who have bone loss like this. You can see when he dislocated, he left a huge divot in the head here. So when the ball came out, his own socket actually pushed in and made this divot in the back. So because of that loss of bone, he's going to be at a higher risk of dislocating again. So more likely to fail physical therapy, more likely to recur, more likely to need an operation. Once we get to the point where we need surgery, typically nowadays we're doing an arthroscopic labral repair. Again, just like the rotator cuff, arthroscopic doesn't speed up your healing. It just makes you have less pain afterwards, less scars, less of an incision. And we still do open stabilizations for certain procedures, for certain conditions. And here's just a video looking at that. So now, this is inside the joint again. And this is that detachment of that labral tissue. So this is the socket, cartilage, and this is the labral tissue off to the side. You can see that the ball that went out ripped that off the edge. And so just like a rotator cuff, the first thing I do here is I actually make it worse before I make it better. So you have to free it up, and sometimes it gets stuck back against the socket. So I'll take this little spatula device and actually help free it up. I want to be able to bring it all the way back up to the socket to create sort of what we call a buffer effect. You want to create that tissue back up there so it holds the ball back in place. Now this is a little hook I have that I bring around and I grab that labrum. And this helps pass a stitch around it. A heavy suture there that there comes an anchor. So similar to the anchor that we saw in the rotator cuff, it's a little bit smaller. We're inside the joint. And that comes down, and what this does now is tacks that labral tissue back up against the edge of the socket. Again, you can see this is the ball, this is the humeral head over here, and this is the socket. You can see how flat it is. I mean, it really is. I always use the analogy that it's like a golf ball on a golf tee, and it really is similar. The ball is much bigger than the socket. And that goes into the bone there. And then I'll do this a couple of times, and I'll do typically at least 3 anchors, and sometimes upwards of 10 anchors around the entire socket if it's a labral tear that goes all the way around, which it does sometimes. Okay, and now here, sort of just after a couple anchors, there's an anchor down here, anchor here, and you can see it's recreated that sleeve tissue up there. Okay, last topic is shoulder arthritis. So here's a nice normal looking ball and socket. You can see no arthritis, no problems. And you can see a clear difference between these two pictures. And so the cartilage is basically gone on here. So cartilage is, for lack of a better term, I think it's like magic shell on your ice cream. So if you have, every joint has two bones, and there's a surface coating on those two bones, and that surface coating is this thin layer of smooth white cartilage. And that's what allows the joint to move smoothly, friction-free relatively. And once that cartilage is gone, you get bone rubbing on bone. So there's no space between the bones anymore. There's bone rubbing against bone. It's very painful. It's very stiff. And what happens is the body tries to stop any movement here. So that's what creates, these are real bone spurs. These aren't the bone spurs that we talked about earlier. These are actual spurs the body creates to try to stabilize that joint and not let it move at all. It's trying to make this area fuse and become one bone. So again, it's a loss of the cartilage surface. Now what causes the cartilage to go away is what defines the type of arthritis you have. So most people have sort of garden variety osteoarthritis. That's wear and tear. You're in your 60s, 70s, 80s, and you present with a picture like this. Now there's rheumatoid arthritis, which is your own body's immune system attacks your own cartilage. So you have these factors throughout your blood, and they go into the joint lining, and they actually destroy your own cartilage. It looks a little different, and there are other problems you can have, like rotator cuff tears along with this, but the bone's typically very soft. It's a lot harder to deal with. Avascular necrosis is an interesting one that you may or may not have heard of. This is something that we see with people who have had to be on steroids for a long time, people who drink heavily for many, many years get this, and you basically get a collapse of the architecture, and it really is challenging too. These patients typically will still have a lot of pain even after surgeries. Then there's post-traumatics. You can see somebody has a bad injury. Now this was treated properly, had a nail put in, but clearly that ball is not recognizable anymore, so this developed a pretty nasty arthritis. Age does not equal arthritis. I have 90-year-olds in my practice who come with shoulder pain, and arthritis is not their problem. Now typically arthritis gets more common as you get older, but it does not mean that you're guaranteed to get it if you live long enough. It's probably a lot of other factors as well. I typically get an MRI scan to look at the rotator cuff, but I also get a CAT scan because it helps me see bony wear. This is a nice solid socket that has a lot for me to work with surgically, versus this one here. You can see that there's huge amount of wear. This is the bone that's where it should be. It should come all the way across, but it's worn a huge pothole in the back, so this makes it more challenging for me to reconstruct. Again, like everything, we start with physical therapy, anti-inflammatories, and injections. I think supplements are very helpful. Fish oil, omega-3. We can talk about that afterwards, but they do seem to help patients quite a bit. And then ultimately, if you're not getting better, then a replacement is done when it's sort of too much to bear for you. This is the first shoulder replacement we've ever done. Things have changed. Now you can see it's a little bit more of a ball and socket. There's a ball, there's an actual plastic socket here. You can tell because this is a little marker we put in so we can see where it is. There are newer types of replacements that are out. You can see if you look at this picture that this really requires something to hold it in, and that something is the rotator cuff. And the rotator cuff has to be competent for this to work. Now luckily, if you have a bad rotator cuff and you have arthritis, we have a newer replacement now. You can see this, there's nothing holding that ball in anymore. It's riding up so much that it's creating a nice curve in the shoulder blade. It's grinding up into the shoulder blade itself because it's so high riding. So we have something called a reverse shoulder replacement. What this does is it actually puts the ball on the socket side and the socket on the ball side. It allows to replace the rotator cuff as well. I'm doing these for fractures a lot more now, so if a patient comes in who's older and has one of these types of fractures where it's just broken into so many little pieces that fixing it, I think, is just going to fail. It's never going to hold plate and screws. It really has no option but to be replaced. And so the reverse replacement has come along as a really viable treatment option for this. And if you get good healing, you can see this is a big, important piece of bone because that has some of the back rotator cuff on it. You can get a really good result. Patients can still get a nice function afterwards. So the only problem really with shoulder replacement is that it's a durable good. You put it in there and it's only going to last so long. So you do have to restrict patients' somewhat afterwards. Bo Jackson, if you guys all remember him, he went back to playing sports after his hip, and now he's on hip replacement number 3, and I think he's pretty much wheelchair bound, so he really didn't listen very well, I don't think, to what he should have been doing afterwards. So you do have to restrict what you do to some degree. I'd be careful with weights and so on and so forth, but most people can play golf and tennis and most activities afterwards. If you do not restrict and you get too aggressive, you can get loosening, you can get dislocations. And again, revision surgery never as good as the first time. So the bottom line is you really wait until you really need it. Here's another patient that I saw who was very aggressive and had pain after weightlifting or something like that. And you can see there was this is the marker down here, and the socket had completely come out of the bone. And if you look at this CAT scan, you can see the outline of the whole socket with the pegs. It should be over here sitting in the bone, but it was sitting out in their soft tissues in the front. There's a dislocated reverse replacement. So again, problems can happen. It's very rare, but it can happen. And if you really need it, you can get a tattoo instead of a replacement. That might be better for a little while. So.
All right, welcome. Thanks, David, for the introduction. So, fortunately, I knew I should have gone first because I don't have any cool videos or my surgeries and stuff like that. But hopefully, this will be a little bit informative for you guys. So, we're going to talk about the foot and ankle. So, he kind of went over this. These are my credentials, and I think the reason I have this slide is because being in the South Bay, being in Los Angeles, you do have options. And so in this day and age of technology and being able to be in touch with like finding out who your doctor is or trained, it's really important these days to have the option to check out your doctor and make sure he has good training and make sure he's the right doctor for the problem that you have. So information's all out there, and it's pretty important to check. So when people come in to see me, oftentimes the problem's pretty obvious. And so you can see on this x-ray over here, this is an x-ray of someone wearing a 6-inch heel, and you can see there's a lot of different, the joints are positioned in a lot different way than they should be, and they're taking a lot more stress. If you wear tight shoes, that can also be a problem. When you look at this presentation, we're just going to talk more basically about the basic anatomy and biomechanics of the foot and ankle, and then a couple common problems of what I see in the office in terms of why my ankle and my foot hurts. What Dr. Magovern was talking about, I'm part of Torrance Orthopedic Sports Medicine Group, and just to go over it again, we've been in the South Bay since 1971, so we're the biggest and longest established orthopedic practice, and we cover all specialties. So if you guys have any problems, we're all a group of like-minded surgeons who are here to, as our mission statement says, to try to get you back to your health and to your passion and what you like to do. Couple of things coming up. We're going to expand our practice to El Segundo. You guys have our new little leaflet there. It's going to be a new facility where we're going to have another option for seasonal physicians, and we're going to also bring in some new surgeons that are trained in the best places in the country, kind of add to be able to take better care of patients. So that's coming in probably July or August. So keep your eyes out. If you look more north, that's an option to go to. So people often ask me why I do foot and ankle, and a lot of people, my colleagues, call it the stinky hand or like the dumb hand, because really it's just on the bottom of the foot, and oftentimes it can have a specific odor, but it's pretty amazing structure. You know, unlike the shoulder, like Dr. Magovern was talking about, where movement is essential. It's a function. The foot has to withstand a significant amount of stress over years and years of walking and weight bearing. So this foot, whether you believe in evolution or creation or not, has become a structure that can withstand much force over the course of decades. And so if you look at like someone walking, the average amount of steps people take on a daily basis is about 7,500 steps per day. If you look at someone who's 80 years old and can average that, that comes to about, probably walk around the world 5 times. So this foot, although people develop problems, is able to withstand a lot of these things, and it's pretty remarkable that they can do that. So when we try to understand the foot and how it's developed, it's hard to deny there's a lot of similarities to the hand. The difference with these things is that the hand is made to grasp things, to use tools, and it needs to move to do these things. The foot has to be a very stable structure so that you can walk on it throughout time without it wearing out and causing problems. So you see different parts of the hand, analogous parts of the foot instead of moving are more solid instead. So when we look at these things, we talk about whenever we see a problem, being doctors and scientists, we want to try to understand like why these problems are happening. And so it's important to kind of hone in on what's really causing these problems. And so whether you believe in atavistic trait, atavistic means passed on from generation to generation, has changed but is still present. The two problems in the foot and ankle that we see that are major causes of this or lead to many problems in the foot and ankle are something called first-rate hypermobility. The other one is calf muscle tightness. So if you look at these pictures, the top picture shows, you heard people having something called a bunion. That's what this is, and that's what it looks like. And it comes from, most of the time, something called first-rate hypermobility. And then calf muscle tightness is pretty self-explanatory. So talking more specifically about first-rate hypermobility, what that means is there's a joint in the foot right here. It's called the first tarsal metatarsal joint. In the hand, if you look down here, it's called the first carpal metatarsal joint. So in the hand, what it allows the thumb to move, so you can grasp objects and things like that. In the foot, it's supposed to be stable. It's the cornerstone of your arch. And so it's not supposed to move. And when it moves too much or is hypermobile, that's where people start developing problems like bunions, for example. And so if you look at these x-rays, you can see this is pretty normal. You see this first metatarsal bone is lined up with all these developments. If you look at the one below, you can see how this bone is kind of tilted out to the side. That's because this joint, the first tarsal metatarsal joint, is a little looser than it should be. So over time, it allows it to kind of drift over and create problems. So bunions are one of the common problems that we see. If this bone is tilted over and not taking the normal pressures that it should, you can develop things like stress fractures and things like hammer toes. And it's also, its job is to be the cornerstone of the arch. And so if it starts being too mobile, not only can it move to the side, but up and down, and it's a major part of people, adults that develop flat foot deformities. The second atavistic trait or thing, primary problem that we see is calf muscle tightness. And this also leads to a large amount of problems that we see in the ankle and the foot. So again, whether you believe in evolution or creation or whatever it is, if you can imagine walking on all four legs, your hind feet, your heels need to be raised in order to achieve that kind of crouch position to walk on all fours. This picture of these people, it's this isolated society, and somewhere in Russia, and basically they have some sort of genetic mutation where they all walk on all four legs. So the details aren't important, but when they look at measurements of these people's range of motion, their calf muscles are probably 10 times tighter than ours, who walk on two legs. So in this schematic, you can kind of get a sense of like why calf muscle tightness would be important to contribute to problems in the foot. If your calf's tight and you're walking, it puts a lot more stress on the front part of your foot, just for the fact that it's tight and it's pushing down in that area. A more normal calf muscle that allows the foot to be planted in this position, the forces get distributed more evenly. The other thing is when the calf muscle is tight, the tendon itself is kind of like a rubber band. So if you hold it really tight for a long period of time, a tight rubber band is going to fatigue a lot faster than something that is less tight. And so we see problems with Achilles tendon and things from chronic tightness of the calf muscle. And so this is kind of a general list of things that are caused by calf muscle tightness. And again, someone may come in with a stress fracture, and you can put them in a cast and make that bone heal, but if you don't treat the primary problem, then there's a good chance it can come back. So just chipping at the tip of the iceberg and fixing these problems might not necessarily make this go away for the long term. So again, it's important to try to figure out what the primary cause of the problem is. So talking in terms of Achilles tendon injuries, one of the more common things we see people come in with back of my ankle hurts, and I'm not sure why. Fortunately, back there, most people can recognize their Achilles tendon. If you look at this cartoon on the left side, you can see these muscles. These are the calf muscles, and it comes down as two muscles and actually forms this tendon. It's their Achilles tendon. So they're all kind of interconnected. And what typically happens is either from tightness or from wear and tear from repetitive stress, the tendon or rubber band over time can start fatiguing. And that's probably one of the more common things I see in terms of pain in the back of the ankle. There's another condition called plantar fascia. That's just the next level down on the foot. Talking more specifically about the ankle, but that's one area. So basically, Achilles tendinosis is wear and tear. Wear and tear of the Achilles tendon, pain in the back of the heel, and it usually works with activities. We're not talking about Achilles tendon ruptures like you see in athletes and stuff, even older people, but same process. People who have Achilles tendon ruptures tend to have tight calf muscles, and it kind of goes hand in hand. So calf muscle tightness is a big risk factor for these types of problems. Oftentimes when people come into the office, they either have an x-ray or they talk about bone spurs, and it's a little different than in the shoulder like Dr. Magovern was talking about. If you look here, you can see on the heel there's a little piece of bone here, and that really isn't the cause of pain. It's a sign that the Achilles tendon, where it attaches to the bone, has been chronically irritated, and when it's chronically irritated, it chronically irritates the bone, and the bone's dumb. It only knows how to do one thing, and it's make bone. So that's what it's. So in the old days, they used to try to shell these out whenever they saw it, because they thought if we don't get rid of the bones for them, the patient never going to get better. They realized people weren't getting better, so they figured out that the problem is the tendon and not the actual bone spurs. So as opposed to the shoulder where the bone spurs can cause potential problems and problems with the rotator cuff, this is a little bit different. In treating all orthopedic problems, as Dr. Magovern mentioned, there's basic tenets, and so resting it is always very important. Oftentimes it's hard to get our athlete patients to rest, but resting is super important. You may have heard the acronym RICE, so rest, ice, compression. These are all things to help keep the inflammation down, give the body a chance to heal these problems. For Achilles tendon specifically, so if you understand the primary problem is the tightness, and you can understand that stretching the calf muscle is the most important thing to help make the pain go away and help make prevent it from coming back in the future. You can do other things like using splints and glutes and stuff like that. These all help, but again, the basic tendon is stretching. Stretching the calf muscle out so the tension is released off the system. Injections are also an option. Obviously, that's not going to stretch out your calf muscle, right? But if your calf muscle is being stretched and you're still having trouble because the tendon is so damaged and worn out, there are other options besides surgery that you can explore. Most specifically, the one I typically try in these types of people are something called flavor-rich plasma. And basically what it is an injection where you use your blood, so we remove your blood like you have normal blood taken, and then we centrifuge it or isolate the growth products and healing factors. And in doing so, we can isolate these growth products and re-inject it back into the area of the tendon that's having trouble healing. And sometimes that can help your body stimulate a healing response. Again, it's not going to stretch your calf muscle, but it can help push you along in terms of healing. When people fail non-surgical treatment, there are surgical options as well. This is pictures of what we do during surgery, and basically what we do is, one, we address the primary problem, which is lengthening the calf muscle. The there's a little bit of a misconception in terms of this kind of surgery and that it's not good or it's not worth it. But if you're the right patient and you tried all these other things and you're not getting better, then it's a viable option. When you look at all the studies and the clinical trials, looking at the results of these surgeries, it's probably about 90 to 95% successful. So most people don't need it, but you don't want to live with an Achilles tendon problem because it's, in the end, fixable. There are other causes of pain in the back of the Achilles ladder, in the back of the area where the ankle where the Achilles tendon is. And so, although 8 or 9 times out of 10 you can come in and assume that your problem is your Achilles tendon, the reason why you want to see an orthopedic surgeon or someone is so that you can make sure that you don't have any of the other potential problems that are mimicking the symptoms, because the treatment may be different. So next we're going to talk about why my ankle hurts, and we'll talk more specifically about ankle sprains and trauma. And to understand that, you kind of have to understand the basic anatomy of the ankle. And so, again, unlike the shoulder, it's a little different. The ankle does have some bony stability. So it's made up of 3 bones, the fibula, the tibia, and the talus. And the bony architecture of the ankle joint can keep it stable. It's also stabilized by these strong ligaments, as well as the dynamic stabilization of the muscles that surround the ankle. So ankle sprains, probably most of us have had one at some point. It's the most common ankle injury. It happens 1 million per year in the United States, it's an estimate. And it usually comes from a twisting type injury, or we call it supination to make us feel smart. But this is typically the way people injure their ankles or sprain their ankles. And it's graded grade 1, 2, 3. If it's 1, it's basically stretching or irritation of the ligament. If it's 3, the ligaments are completely torn. There's a version of it called a high ankle sprain. The other ligament, or the ligaments that are holding the tibia and the fibula bone together, are disrupted. And so these details aren't important, but what's important is that even in the worst cases, grade 3 ankle sprains, probably 80-90% of people will get better without having surgery. So this is usually used to help us classify and treat patients in different ways. So again, just like the Achilles tendon, the tenets of treatment include resting it, icing it. Sometimes with a bad ankle sprain, to protect it in something like a cam boot or a cast. Ankle braces are oftentimes helpful. If the ankle ligaments are loose and it's causing the ankle to be unstable, using something to stabilize the ankle can be helpful. Physical therapy oftentimes is a good way to help get the muscles back and the joint moving better so that you can get back to your normal activities faster. And typically people get better within 3 to 6 weeks of resting in treatment like this. So what happens if you're the unfortunate person that doesn't get better with an ankle fracture? Well, I'm sorry, an ankle sprain. Well, you want to check it out. And that's the reason, another reason to see your doctor is, yeah, most of the time it's an ankle sprain, most of the time it'll get better, but what happens if you're not better? Well, you can have a fracture. Just because you can walk on it doesn't mean you don't have a fracture. This is an x-ray of a patient who had a pretty non-displaced fracture, so there's cracks through the bone, but the bones aren't out of position, so you may think it's okay, but it's a very unstable ankle fracture, so it's something that needs to be fixed potentially. So that's that. If you injure your ankle ligament so much that the ligaments become loose, the ankle, besides the bony stability, can become unstable. So you can have recurrent injuries. You can roll your ankle multiple times, and it can potentially damage the joint itself because it's moving more than it should. Impingement issues mean that whenever you have an injury to any part of your body, the body tries to heal it and reform scar tissue. So with the bones moving, sometimes scar tissue can build up enough that it causes irritation to the tissue around it, called these impingement problems. And you can tear the tendons around the ankle joint as well. One of the most important parts of the ankle joint is cartilage. And the cartilage is basically the smooth surface inside the joint that allows it to glide. So it's kind of like an ice rink. So if you have an injury, chip off a piece of that cartilage. It's kind of like having a pothole in a smooth surface that you slide smoothly, so it can create problems. This is an MRI scan of ankle in someone who is injured, and this area is a place where the cartilage was kind of chipped off or damaged. this picture is an arthroscopic picture where we're looking into the ankle with a camera. This bone is called the talus bone. The white stuff is normal cartilage. This underlying tannish type tissue, that's bone underneath it. So this person was having continued pain because they have a divot in the cartilage that allows the ankle bone to glide. We also want to see, well, did this person injure their ankle because they stepped on someone's foot, or did it happen just from walking, or did it happen because they have some other problem that is giving, is a more of a risk factor for them to roll their ankle like we showed. So one of the things is a high arch foot, and so if your arch is high, you're more prone to tilting over. The ankle is inherently loose. Some people are born with loose ligaments. You can be more prone to injuring your ankle that way. This person has a disease called Blount's disease, where the tibia bone actually is heard of bow-leg people. The tibia kind of develops in a little bow-legged position. So you can imagine if you're tilted out like that, it puts abnormal stress in your ankle, and that can lead you more, make you more prone to injury. So the point of this is that, besides treating the obvious, you always want to make sure that you're treating the primary issue so these things aren't missed, and then you don't have your ankle fixed and still have problems related to these types of issues. So ankle sprains, again, same way, can be treated most of the time as conservative treatment, non-surgical treatment, resting it, icing it, that sort of thing. Physical therapy, again, is an important part of this type of treatment. It can help get the muscle stronger and the range of motion better, faster. It'll get you back to doing what you want to do. In these types of situations, at some point, sometimes steroid injections and a platelet trial and that kind of thing is appropriate, usually not as a first step, though. So, if you do become one of the lucky persons that continue to have pain or problems after an ankle injury like this, there are good procedures to fix this. And these procedures have been around for decades, so they have very good track records. Usually the most common thing we do when we have someone with an unstable ankle is basically tighten up the ligaments that are already there. So if you have an ankle sprain and you stretch out the ligaments, you just use your own tissue and tie that back up. And most people do pretty well with these kind of things. There are other kind of more complex ways to reconstruct these ligaments, but that's primarily what we do. In terms of problems inside the joint, like this is the arthroscopic picture of the cartilage defect. You can address most of these with a pretty small incision. We have this thing called arthroscopy, which is just a small camera and little instruments that we use to fix these things without having to big open incisions. So in this example, what we do is something called a debridement and microfracture, where basically we take that damaged cartilage and we remove the damaged pieces of cartilage, because that's what we think are one of the causes of the ankle hurting. So we remove the damaged, non-viable cartilage, and then we poke holes in the bone underneath the cartilage. And what that does, it allows your body to produce blood flow. And the blood flow will help produce something called fibrocartilage. And fibrocartilage is like a cushion. It's not normal cartilage, but right now, the best way we have to get these things to heal. We don't have any predictable and consistent ways to regrow normal cartilage. This is the next step in this phase in orthopedics. At some point, we're going to have some sort of injection or have some sort of drug that can reproduce normal cartilage, and this is going to end the age of knee replacements, ankle replacements, things like that. But that's still far away. So this is a good option and can be done pretty effectively. If there's any tendons torn during the injury, you should always repair those at the same time. So leading on to the other issues, ankle arthritis. So what does that mean? Well, we kind of talked about it. So ankle arthritis means the cartilage is all worn out. So instead of having a little pothole like this, all the cartilage is gone. People present with pain and stiff ankle that they have trouble walking on. And it can lead to progressive deformity. Remember, you're always walking on this ankle that has a problem. And so over time, you can develop a deformity as well, meaning your foot can become more flat or your foot will tilt the other way because the wearing of the joint is not always the same. So if you look at this, these are arthroscopic pictures. The top picture, that's normal, normal ankle joint. So you see this white glistening stuff, that's cartilage that we saw previously. If you look at this arthroscopic picture, this is someone with bad ankle arthritis. So all this pink tannish stuff, that's all bone. So on the x-ray, you see these two bones pretty close together compared to a normal joint right here. That's because all this white stuff is all worn out. That's arthritis. So arthritis, as opposed to other joints like the knee or the hip, usually comes from previous trauma. So if you have a bad ankle sprain that was loose over years and years and years and never healed, you can develop arthritis. You had an ankle fracture that was treated, or you had a bad ankle fracture that healed bad. These are the reasons people develop ankle arthritis, mostly. But like I said, if you have a loose ankle over years, you can have arthritis. If you have a foot malalignment issue, like that kid that we saw, or that person we saw that had to tilt the bow legs, because of the abnormal stress over years and years of walking, that can lead to problems like arthritis and early wear of the joint. You have rheumatoid arthritis or problems inside your body that are attacking the cartilage in the joint and also lead to it. If you are an unfortunate person that develops an infection around your ankle, then that can also be a factor too. So how do we treat this? Well, it's very similar to all the other things, being an activity modification. If you have ankle arthritis, you probably don't want to train for marathons. Maybe you want to swim. It puts less stress on the joints. Correct the primary problem. So the arthritis is caused by a malalignment issue or your ligaments are too loose. You want to fix those things as well as fix the problem of your arthritis. There are a lot of braces, custom braces, open counter braces that you can use to stabilize the ankle when you walk. So just having that ankle arthritis doesn't mean you have to have surgery. There's these kind of techniques. Physical therapy doesn't make the ankle arthritis go away, but if you stabilize the muscles and keep things flexible, puts less stress on the ankle joint. Sometimes people get functional okay that way. Medications like anti-inflammatories are oftentimes helpful, and injections are a big part of treating ankle arthritis. With platelet-rich plasma for severe arthritis, we can't imagine that it's going to regrow normal cartilage, but stuff like steroid injections and things like that are oftentimes helpful to take away the inflammation that the arthritis is causing, which in turn relieves pain in the symptoms. So when people don't get better with these things, we start thinking about surgery. And the reason to do surgery is if you have pain affecting everyday activities and you've tried all these non-surgical things and you're still having issues with your daily life. It's not because someone took an x-ray of your ankle and said that you had bad arthritis in your ankle. We oftentimes see people come in for other reasons to get x-ray of their ankle and it looks like bones are rubbing against each other, but the patient is fine. So you never want to treat the x-ray image or what someone tells you you have. You have to always match it up with your symptoms because you may get treated unnecessarily. So the main thing is your symptoms. So pain with everyday activity, and if you failed or did not respond to all the non-surgical options. And the goal is obviously to relieve the pain and allow you to restore normal function. So the surgical options for ankle arthritis are basically three. Something called ankle arthroscopy, where we just go in there and we clean up the joint with a small procedure. Sometimes we add this device, it's called an Alizarov device, where we put these wires in your tibia bone and your foot and we stretch out the joint for a certain period of time. We think that may help promote something called fibrocartilage growth, like we were talking before. But it's a long procedure, and for someone that's young with arthritis, that may be a viable option. But in general, that's sort of how we treat arthritis when other options are not reasonable for that patient. So the mainstay of treatment for treating ankle arthritis that's severe and the bones are rubbing are either something called an ankle fusion, and the other one is an ankle replacement. So just to show you this picture, again, this is a picture of the ankle that has bad arthritis. And basically what we do is we use this device and we clean up all the scar tissue, the debris, and all that different things that occur in arthritic ankle joint. And through this, a certain percent of people get pain relief. arthroscopy is not a permanent fix, but if it's someone who's 30 years old that is not going to have an ankle fusion or an ankle replacement, this may be a viable option. Or if you're on the flip side and you're 70 or 80 years old and you just want to walk, and this may be an option, but there's a lot of different nuances in terms of treating these things, but it's not a permanent fix. So the gold standard, the treatment that's been around longest for severe ankle arthritis is something called an ankle fusion. When we talk about ankle fusion to patients, oftentimes it's a pretty scary thing. Hey, I'm going to use this structure that's moving all my life to make your pain better. And so basically what we do is we stick the tibia bone and the talus bone together and hopefully make that into one bone. So again, unlike the shoulder, which in the old days, when people had that arthritis, they didn't have shoulder replacement, so they fused those joints. And people had functional problems because their shoulder needs to move to function. So it's important to understand what joint you're fusing, what are the potential problems that can happen with that. With an ankle fusion, you can function well and have a normal gait. The idea of this, again, the main goal of the surgery is to relieve pain. So people who have severe arthritis, usually their ankle joint is pretty stiff anyway. If you take away that pain, people tend to walk pretty normally. It does become more stiff, but there are 3 joints around the ankle joint that act to move the ankle, or the foot up and down as well as side to side. So your motion isn't completely stuck. You're not walking on a peg or a prosthesis. There is still some motion involved when you have an ankle fusion. And so the benefits of doing an ankle fusion is it's predictable because you're trying to get 2 bones to fuse together. Pain relief. So when you ask people like, I had an ankle fusion, was it worth it? Probably 90% of people say it is because of pain. And it allows them to get back to their normal activities. And you can maintain some up and down motion. It's these 3 joints. There's a joint here called the subtalar joint, and a joint here and a joint right next to it that allows still the foot to have some up and down motion. So the stresses that this joint absorbs is now being absorbed by these other 2 joints that we talked about. So potentially those joints can wear out faster if your ankle joint is fused. So that's one potential downside. So this is how we start thinking more about, well, what if we try like they do with the knee and the hip and ankle replacement? Historically, it's kind of had a bad rap because I think in the 50s and 60s, the first attempts at ankle replacement were not very good. So the short-term and mid-term results in terms of patients continuing to have pain relief or the implants maintaining the normal positions weren't the best. But probably over the last 10 to 15 years, the technology for ankle replacements has become really good to a point where I feel like you can offer this to patients as a safe and viable option. And again, you have to be the right person, and it's not as simple as I have an ankle arthritis and I want an ankle replacement. There's a lot of factors that go in, and probably some of the longest discussions I have with patients when we're counseling them in the office is when they have ankle arthritis is talking about this. Should I have an ankle replacement or should I have an ankle fusion? There's definitely pluses and minuses as well. This is a schematic of the ankle replacement that I actually use. And basically what we do with this is we replace the damaged bone with metal, and in between the metal there's plastic. So this plastic is what we worry a little bit about over time wearing out. And so you can see these x-rays. It's an x-ray of an ankle replacement. And the benefit of today's ankle replacements is we try to restore the anatomy back to normal. We try to put the implants in when we take away bone back to as normal as possible. We want to restore normal anatomy and the normal alignment of the ankle joint. And that minimizes wear and wearing out of these kind of things. And so nowadays we're able to achieve this by the new technology. So in this example of this ankle replacement of this cartoon, this is a device that we use to fix the ankle in the right position. This is guided by an x-ray machine in the operating room. So once we know that we have the foot and the ankle in the proper position. With X-ray, we can safely and predictably put these implants in the right orientation, in the right alignment, and it's predictable. And so these are the kind of things, along with the type of material that we use to create these implants, that we can safely say, yeah, this is going to last you for X amount of years, depending on how you put pressure on it. So again, ankle replacement is definitely an option when all else fails. So similarly to an ankle fusion, what are the pros? One, it relieves pain. And so when you compare people who have had an ankle replacement versus people who have had an ankle fusion, both groups, the majority of the patients report that they're doing well. And the main reason, like we talked about, is because it relieves pain. Both are predictable in relieving pain. The nice thing about the ankle replacement is it maintains motion, so maybe these other joints will wear out faster, and maybe functionally you'll be more have a more normal walk and functionality than if your ankle's one of those fused. And like I said, it decreases the stress on the other joints. The cons are that you have to remove bone to put these implants in. So if you are 30 years old and you have bad ankle arthritis and you take out a lot of bone and put this implant in, 30 years down the line, if this ankle replacement wears out, there's less bone to work with. So can you fuse it? Maybe. Can you replace it with another ankle replacement? Probably. But each time you do this, you're taking away bone. So that's one of the potential cons or negative sides of doing an ankle replacement. And also, we are putting implants in. So over time, with the repetitive stress, these implants can loosen. And the plastic in between the metal can wear out and cause issues too. So these are all things that we continually try to strive to make better longevity-wise, and making sure that these implants stick to the bone. And so it's starting to get to the point where it's starting to match the results of the hip replacement. It's probably not as predictable, but starting to get there. All this technology in terms of the plastic and the metal and the way it fixes the bone, this is all borrowed from the hip and the literature and studies, technology. So when you ask a general question, I have severe ankle arthritis, what's right for me? You don't know. I mean, that's why it's important to talk to your doctor, because they can give you all the options and see your medical history, see your activity level. There's a lot of things that go into deciding on what treatment to have. And so we like to think that we could do a little bit better than a computer screen and the internet. It's not so straightforward with these things. So if you're in this market of trying to get your ankle better, then it's worth the consultation with an orthopedic surgeon. So in summary, any kind of foot and ankle problem, you have to identify the primary problem, because that's usually the main way we try to treat these things. Most treatments can be treated non-operatively, and when all else fails, surgery is definitely a viable option for those that need it. That's it.
Game changer. As far as rehab is concerned, the rehabilitation for a shoulder replacement is way easier than the rehabilitation for a rotator cuff repair. Again, that rotator cuff repair is done through small poke holes in an outpatient setting, but it takes 6 months at least to get over. Shoulder replacement is definitely is about half the length of time that it takes to get over than the rotator cuff repair. The reverse is faster than the conventional shoulder replacement. So conventional shoulder replacement, I have to take one of the rotator cuff muscles down to do the surgery. That has to heal for it to work properly. In the reverse, there's no healing per se that has to happen. I go in, I put the implant in, and really all I need to happen is to get a little bit of of scar tissue buildup, so it's less likely to dislocate. So my rehab for shoulder replacement is 4 weeks in a sling doing nothing. And then the next 8 weeks of just using it for functional life. So using it for driving, using it for eating, bathing, dressing, cooking, those sorts of things. And then after 3 months, you can do whatever you want to do with it. If it's done for this, for rotator cuff tear and severe arthritis in the right age group, so again, 65, 70, that's more a discussion like Dr. Park said about being with the patient discussing pros and cons, but when it's done for the right diagnosis and done properly, range of motion is fantastic. Patients typically get arm 170 degrees range of motion, good external rotation, good strength, good function, and very, very, very minimal pain. So this really is one of my favorite procedures to do, reverse shoulder replacement, because I think the outcome is really good.
It's a good question, because a lot of these problems can be treated or can be prevented by doing the right thing. And so specifically talking about these problems in the foot and ankle, as you saw, stretching, keeping things flexible, keeping the muscles in condition are all very good preventative ways to will help prevent these problems from developing. Other things like shoe modifications or getting the right kind of orthotic made, those are also potential options. And so depending on what specific problem you have, there's definitely things we can do to help prevent these things from happening and hopefully help you avoid having terrible surgery.
Again, the history and physical is so important to us, but that really gets us 80 to 90% of the way there. So the images are important, and they are an important piece of the puzzle, but we've already narrowed it down to 2 or 3 possible diagnoses by the time we're ready to get the images done, which is why when we order an x-ray or an MRI or a CT scan, it's very specific to help us distinguish between 2 or 3 different diagnoses. So if you're 22 years old and you're coming in with shoulder pain, odds are you're not going to have a rotator cuff tear or arthritis. You're going to have instability or something else that happens in younger patients. If you're 85 years old and you have stiffness and soreness, it's going to be arthritis or something else like that. So I've already, just seeing your age and your complaint, I've already got an idea what it is, and each piece narrows it down more and more. So it is something that we use, and that's what Dr. Park said about you can't just plug this stuff into a computer and get an answer. So yes, you're 22. It's extremely unlikely that you have a rotator cuff tear. I've probably fixed 1,000 rotator cuff tears, but 3 of them were in patients in their 20s. So it can happen, but you have to sort of play with what the odds are. And then physical therapy, I think nowadays most insurance plans allow you to see a physical therapist 3 or 4 times before getting your diagnosis made. I think that that's a fair number of visits to try physical therapy before seeing somebody. I think 3 or 4 visits with a physical therapist, given that that's where we start with 90% of the diagnoses that people have. And typically, unless it's a traumatic injury, if you're worried about a fracture, if it's something that is repetitive use, wear and tear, I think 3 or 4 visits with a physical therapist is very reasonable to see if that gets you on the right track. And oftentimes, if they can get your home exercise program and your symptoms go away, you're probably in pretty good shape.
Temporarily, that's a good question, and it sort of depends. If you have arthritis in the joint, the steroid injection is not going to rebuild normal cartilage. So it is used to take away the inflammation that's causing pain. However, in other situations, like if you have a chronic tendonitis, which means inflammation in your tendon, and the physical therapy or the treatment you're having isn't getting better, and your body can't clear that inflammation, then sometimes it is permanent. So some of the times you inject a steroid around the tendon sheath or covering of the tendon, and it can help your body take away that inflammation, kind of break the cycle of inflammation that's being caused, and it can sometimes be a permanent fix. Again, it depends. If you have an ankle brace that's rigid, that doesn't allow the ankle to move at all, yeah, it can cause the muscles to get weak and cause the joint to get stiff. But if you have a functional ankle brace that provides some support and stability for if you have a problem with your ligaments have been loose over time, and your ankle's still moving normally, but you have the brace to kind of support it from getting abnormally too loose, then it's functional, and in that sense it would probably not cause problems with the ankle in terms of weakening the ankle, but it will help it because it would prevent it from being injured.
We see this all the time, and it's very hard to say. And the answer is, I don't know, and I won't know until I see you, and I'm not sure that I'll know until you've seen me and you've seen a neurologist, but this is something that we see all the time. So as a shoulder specialist, I'm going to see neck issues causing shoulder pain, and I'm going to see shoulder pain causing shoulder pain, and I'm going to see nerve pain causing shoulder pain. So all of these things can contribute, and there are so many subtleties between the history that I take and the physical exam that I take, and then the tests that we do. So this gets back to the question of, can you make an accurate diagnosis without an x-ray and MRI? This may require a nerve test or some other type of test. So if we're ordering, people might say, well, why am I not getting an MRI scan? Because an MRI scan is looking for very specific things, and something like this doesn't sound like typically an MRI scan that I would get. So I guess the answer is that anything like this can always start with an orthopedic surgeon. Any type of extremity complaint, any type of pain, any type of burning sensation, whatever it may be, can always be seen by us. And I meant to say this during my talk, I think one of my favorite things about our group as orthopedic surgeons is that I think we are by far the most conservative group around as well. And I think that's important. I think we really take pride in the fact that we don't just operate on everybody that comes through the door. And so I feel very comfortable seeing this and realizing that, you know, hey, I'm not looking to just operate on this person. I'm looking to make this person better. So I have no problem sending this person to my spine partner who will look at his or her neck, or to a neurologist across the street who can check the nerves out. And so really, I feel comfortable sending to Dr. Park or to anybody in my group and knowing that they're not going to get unnecessary surgery, and we're going to really think through it and try to figure it out. So that's a long answer for saying I'm not sure, but I'm happy to help figure it out.
So PRP, like we talked about, you're drawing the blood from your peripheral blood. We do think that there may be some stem cells. Stem cells are the cells that produce organs and produce the things that they basically develop into all parts of our body. So we hope that in the peripheral blood there's some floating around, and we hope that with a PRP injection we can isolate some of those. Those would help things like a bad tendon heal. A stem cell injection is a little bit different in the sense of where we get that blood or tissue fluid. So one of the places is in your pelvis. The pelvis has probably the most stem cells in the body, and so sometimes we can take fluid from the bone marrow and use that to isolate the growth products and hopefully have more stem cells in it. So it's a little bit different in a sense of the location, but it's a similar process. The PRP is different in that you can draw the blood and inject it in the office. To take someone's bone marrow from their hip, typically we do it in a surgery center or a surgery situation because it can be a little uncomfortable, but that's kind of main differences. They did a study in the South Bay actually, looking at female high school volleyball players and put ankle braces on all of them. So they looked at, does this decrease the amount of times these athletes injured their ankle, or did it minimize the severity of the ankle injury when they had it? And the incidence, or the amount of times people sprain their ankle, or these athletes, is about the same. The severity of the actual injury was a little bit less with an ankle brace. So what I typically tell people is that if you have a normal ankle and have never had any problems with your ankle before, I'm not sure that it's necessary to use an ankle brace. However, if you had an ankle sprain in the past and your ankle feels a little loose or you want more protection because you've hurt it before, then I think that's a good reason to use an ankle brace. Hammer toes, and it's all based on your symptoms. So I've seen patients with toes that look like they want to fly off their foot, and they're doing fine because they use different kinds of shoes. They cushion their toes so they don't rub on things, and some people do okay. On the flip side, some people come in and their toes curling and they have a hammer toe and it's super severe, affecting their daily life. If that's the case, that's when surgery is a possibility. Again, we always try conservative things like changing the types of shoes you wear or using straps or cushions to protect it. But it's really based on the symptoms. So if your hammer toe is affecting the things you like to do on a day-to-day basis and these normal things aren't working, then surgery is an option.
There are muscles and tendons similar to the rotator cuff in the hip, but they're really not as important. So imagine you don't have to pick up a ball and throw with your foot, so the hip socket doesn't have that same necessity of holding it in. But there are, so there is not a rotator cuff in the hip. There are some tendons that can be affected. It's a lot less common. We have a partner in our practice, Dr. Huber, who does a lot of hip surgery and hip arthroscopy. And he's starting to do a lot more of these tendonitis repairs and so on and so forth, but it's less common. Hip and knee replacement are the most common replacements out there, so shoulder, elbow, and ankle are less common, but the hip replacements are probably the ones that last the longest of all of them. So now the technology has really come a long way, and the hip has so much bone to work with that between the implants and the availability of space to put implant and hip replacements are very likely to last 30 plus years. I'm hoping my shoulder replacements are lasting 20 years. Dr. Park is probably similar, but really 30 plus years I think you should expect from your hip replacement. Rarely, and there are a few instances where we acutely will fix a separated shoulder, but for the most part, shoulder separations can be tolerated very well. Most professional hockey players and contact athletes have had 1 or 2 separated shoulders and treat them non-operatively, and function is 95% great without surgery.
You want to make sure that you're treating the right problem. You can feel where the peroneal tendons are, and you can assume that that's a problem. Maybe in most times it is, but I think the first thing to do is get a proper diagnosis and know that that's what you're treating. Because if truly you're found to have peroneal tendonitis and you're an athlete, then most commonly you would start off with things like resting if it's hurting really bad, or starting off with a functional physical therapy program to help your body take away the inflammation around the tendons. If it's something that's been chronic and not getting better, then there are other options. Steroid injections, platelet rich plasma, and pretty rarely surgery for that problem. So basically, hammer toe can be caused by many different things. The most common reason these develop is because of the hypermobility in the first ray. That first bone is not taking the normal pressure that it should, so it transfers the weight to the other joints, and that's what leads to the joint getting out of place and causing the joint to curl. Muscle imbalances, neurologic problems, bad shoe wear, things like that, that can also affect the formation of a hammer toe. The treatments are usually based on either changing your shoe wear to accommodate the hammer toe, or changing your toe to accommodate your shoe. We usually start off with the first.
Good question. Cold weather affects every joint. It affects anybody who has arthritis, who's had previous surgery, who has hardware still in place. It's not uncommon to have some discomfort and some symptoms in the cold weather. I think that it probably has to do with blood flow is my thought. As temperature gets cold, blood is restricted to those body parts typically, and I think that without that blood flow, things sort of shut down and stiffen up. The blood doesn't come in and clear out waste like it usually does. So typically in cold weather, if you're having soreness, the answer would be to heat it up, get things moving, and do what you can. Arthritis, and I found exercise in the pool helps me most. I think pool exercises are great. It takes gravity out of the picture, so if you're putting a lot of force across an arthritic joint, having that anti-gravity environment is really helpful to get mobility without the same degree of force across the joint. Omega-3 fish oil, I tell patients that I don't take it, but I sure should, and I would if I started having issues. But I tell patients to I don't have specifics on doses, but basically go to Costco, get the biggest bottle you can, and take it as directed. And give it 2 to 3 weeks, or even a month. And if it doesn't work for you, if you don't notice a difference, then it's probably not going to help very much.
It's a ligament on the bottom of your foot that's softly interconnected with the Achilles tendon and then your calf muscle. So this is all one chain, your calf muscle, your Achilles tendon, and your plantar fascia. So again, the plantar fascia symptoms or problems, those are the symptoms. They're not the root cause. The root cause is the tightness. And so when we have patients come in with plantar fasciitis, a lot of people say, well, I heard my friend had a steroid injection and it felt better. And yeah, you can do steroid injections to make it better. Are you solving the primary problem with the tightness with a steroid injection? Probably not. So it's an option, but the mainstay treatment for plantar fascia is to get things stretched out, and probably 95% of people will get better from whatever treatment you have with plantar fasciitis. The hard part with treating this problem is it's hard to predict patient to patient how fast they're going to get better. It's not like a fracture where you can say, in 6 weeks the bone's going to heal pretty strong. It's something that can take 6 weeks, 6 months, 2 years. That's the hard part. So. I've been answering questions a lot like this, but it really depends. Depends on what's causing the bow legs. Most people that get evaluated with kids with bow legs are something that has it happens in infancy, and over time as the kid grows, they usually grow out of the bow leg, at least enough to where it's not going to cause any functional problems. If you have a problem like Blount's disease, like we saw in my talk, then the treatment may be a little bit different. So in general, pediatric orthopedic surgeons, I think, are using these bars and braces a little less and less for the foot, using bars and braces to treat flat feet with little babies and kids and stuff like that, special shoes. That hasn't panned out to be really effective because in the end, as a kid grows, for example, a flexible flat foot is fine over time. So a lot of the things that they were doing in the 40s and 50s to these kids with flexible flat feet, we don't do anymore because it usually doesn't make a difference because the kid's okay anyway in the long term.